nucleotide metabolism. And just as a reminder, I want to show you the structure of nucleic acids. Remember that nucleic acids have three parts to them. There's a phosphate group attached to a pentose sugar, which is attached to a nitrogenous base. And remember, it's the different types of nitrogenous bases which are added to the pentose sugar which determine the structure and function of the nucleic acids. Now, there are 5 different bases. There are the purines, which are adenine and guanine, and their nitrogenous bases are shown here. And then the pyrimidines, which are cytosine, thymine, and uracil, which are shown here. The purines have 2 rings. The pyrimidines have a single ring. Now, we're first going to talk about purine synthesis, and you can imagine this is a complicated process. It has this complex double ring structure. Now, the atoms of the rings are derived from different biosynthetic precursors, and we're not going to talk about the details of how all this happens, other than to say that it comes from a lot of different sources, and many are things we've talked about already. For example, this carbon here comes from carbon dioxide. This nitrogen and these 2 carbons come from glycine. Here's a carbon that comes from tetrahydrofolate. Here's nitrogens from glutamine, another carbon from tetrahydrofolate, and a nitrogen from aspartate. So from a lot of different source material, these purine rings are synthesized. Now, purine synthesis starts with a molecule of ribose. And the type of ribose we use is called PRPP. It's actually activated ribose with the phosphate already attached. The addition of an amino acid group to that activated ribose is actually the committed step. The basic ring structure is called inosine. And then that ring structure is modified to form guanosine and adenosine. Okay? So here's a schematic version of this. We have ribose 5-phosphate. We activate that to form PRPP. And then onto that, we start adding these different components to form the actual purine ring. Okay? And then that purine ring, which is inosine, gets modified, again, to form guanosine and adenosine. Now, purine synthesis is primarily regulated by negative feedback inhibition of all these synthetic enzymes. All purines inhibit that first committed step, the formation of 5-phosphoribosylamine from ribose 5-phosphate. And this ensures that we don't produce more purines than we need to. Now, the other thing that's important is you need roughly equal numbers of AMP and GMP. And so AMP inhibits the conversion of inosine monophosphate to AMP, and GMP inhibits the conversion of IMP to GMP. And this keeps the proportion of AMP and GMP roughly equal. The pyrimidine bases also have a single common ring structure, and this is derived from carbamoyl phosphate and aspartate. Only 2 components this time. The pyrimidine bases, unlike the purine bases that are synthesized on the ribose sugar itself, the pyrimidine bases are synthesized first and then are added as an intact unit onto the ribose sugar. The first step of pyrimidine synthesis is the synthesis of carbamoyl phosphate by carbamoyl phosphate synthase 2. Now, this is a different enzyme than the one that we saw in the urea cycle. The basic ring in this case is called orotate, or orotic acid, and then it's modified to form UTP. UTP then could be modified to form CTP. So here it is schematically again. We take glutamine, and using carbamoyl phosphate synthetase 2, we form carbamoyl phosphate. Okay? And that then is converted by a number of steps to orotate, which is converted to UMP, converted to UDP, to UTP, and then that is modified to form CTP. Now, remember when we were talking about urea cycle defects that we saw this compound, orotate or orotic acid, in the urine. The reason that happens is because one of the things that accumulates in ornithine transcarbamylase deficiency is this compound carbamoyl phosphate. So the carbamoyl phosphate, since it can't be metabolized in the urea cycle, it's metabolized via this alternative pathway to form large amounts of orotic acid. And that orotic acid then is excreted into the urine and becomes an important diagnostic tool in the diagnosis of urea cycle defects. Now, pyrimidine synthesis is also subject to negative feedback regulation. UTP, which is the first nucleotide formed in this process, is a negative feedback inhibitor of the carbamoyl phosphate synthetase 2. And remember, that's the step that's the enzyme that catalyzes the first and regulated step in the de novo synthesis of pyrimidine nucleotides. Now, everything that we talked about so far is the formation of ribonucleotides. These ribonucleotides are used in RNA synthesis, obviously, but they need to be converted to deoxyribonucleotides. And this is done by an enzyme called ribonucleotide reductase. The reducing power that allows this to be reduced is provided by a protein cofactor called thioredoxin. Now, this enzyme, this ribonucleotide reductase, is inhibited by a compound called hydroxyurea, and this is used as an anti-proliferative drug to treat certain types of cancer. Now, everything we've talked about so far has included the bases that are seen in RNA. What we haven't talked about is thymidylate synthesis. Now, thymidylate is synthesized from DUMP. Remember that thymidine is only seen in the DNA form. You don't see thymidine in RNA. And so thymidine is actually synthesized from a deoxynucleotide, deoxyUMP. And the enzyme responsible for this is thymidylate synthase, and this methylates the pyrimidine ring to form DTMP. Now, the methyl group is donated by tetrahydrofolate, and the tetrahydrofolate, unlike other reactions in which it donates methyl groups, is actually oxidized to dihydrofolate in the process. So in order for tetrahydrofolate to continue functioning in thymidylate synthesis and other reactions, it has to be recycled from dihydrofolate. The reduction of dihydrofolate to tetrahydrofolate is catalyzed by an enzyme called dihydrofolate reductase. This enzyme is also responsible for the synthesis of tetrahydrofolate from dietary folate. So dietary folate is converted to dihydrofolate by DHFR, and then the dihydrofolate is converted to tetrahydrofolate by that same enzyme. Now, because this particular product is important in DNA synthesis, this protein is an attractive target for cancer therapy. In fact, there's a drug called methotrexate that inhibits dihydrofolate reductase. Methotrexate is a folate analog. It looks a little bit like tetrahydrofolate, and it actually competes with tetrahydrofolate for the dihydrofolate reductase. When dihydrofolate reductase is inhibited, the cells essentially become starved for tetrahydrofolate. So it can't synthesize purines, and it can't synthesize thymidine. And without the nucleotide synthesis, the cells can't divide, and they die. Now, this affects not only cancer cells, but it also affects any cell that's actively dividing. So blood and GI tract cells, hair cells, for example, are also sensitive to this treatment. So so far we've talked about how the nucleotides are made. Let's talk about how the nucleotides are destroyed. The first step in nucleotide catabolism is the removal of the bases from the nucleotide. And this leaves a ribose 1-phosphate which can be degraded or recycled. The pyrimidine bases are degraded to beta amino acids, to carbon dioxide, and to ammonia completely. And these are utilized, either excreted or utilized in other processes. The purine nucleotides are converted to xanthine. Xanthine is oxidized into uric acid, which can be excreted by the kidneys. Now, an important part of the purine nucleotide economy is the salvage or the reutilization of free purine bases. These free purine bases, once they're removed from the sugar, are able to be recycled and converted back into the corresponding nucleoside by combining them with the activated ribose, the PRPP. And the process is shown here. So here's an AMP, here's GMP. AMP is converted to IMP, and then the nitrogenous bases are removed from the phosphate. So you have just guanosine and inosine, then they're converted to guanine and hypoxanthine. Hypoxanthine is the name of the nitrogenous base on inosine. Okay? Now there's an enzyme called hypoxanthine guanine phosphoribosyl transferase, or HGPRT, which is responsible for taking these nitrogenous bases and adding them back to PRPP to reform the nucleotide. In this way, we can recycle these nucleotides. Now, those that aren't recycled, the hypoxanthine and guanine, are converted to xanthine. There's an enzyme called xanthine oxidase, which converts those then to uric acid, and then the uric acid is excreted in the urine. Now, a defect in this pathway causes the disease illustrated in the following clinical vignette. A 6-month-old girl is admitted to the hospital for pneumonia. Her primary care physician is concerned because she's had recurrent upper respiratory infections, otitis media, and thrush since birth. She's also fallen off her growth curve from 75th percentile at 2 months to 10th percentile now. Lab tests show a normal white blood cell count, but an extremely low number of lymphocytes. This patient has a disease called severe combined immunodeficiency syndrome, or SCID syndrome. SCID is a general term that's used for a group of diseases, a group of disorders of lymphocyte function. About 50% of these cases are caused by a specific enzyme deficiency. The enzyme is called adenosine deaminase, and this is the first enzyme in the adenosine degradation pathway, as shown on the right. This defect in adenosine deaminase causes accumulation of deoxyadenosine and deoxy-ATP, which in large numbers are toxic to the lymphocytes. This accumulation eventually leads to inhibition of other enzymes like ribonucleotide reductase and blocks DNA synthesis. So the loss of these lymphocytes causes immunodeficiency. The patients exhibit failure to thrive, and they suffer from recurrent infections, especially opportunistic infections like thrush, cytomegalovirus, and pneumocystis carinii pneumonia. SCID can also be caused by a defect in purine nucleoside phosphorylase, which causes toxic accumulations of purines. And this, remember, is in the conversion of guanosine to guanine in the process by which these nitrogenous bases are removed from the sugar backbone. There's other SCID syndromes as well that are caused by immunologic deficiencies that we won't talk about. Now, another defect in this pathway is illustrated by this clinical vignette. A 3-year-old boy is brought to his pediatrician. His parents are concerned because he's constantly chewing on his fingers and lips. He chews on them until they bleed and leaves open sores. A review of his medical history is significant only for a little bit of delayed motor development. He has a slight macrocytic anemia, and he has a significant elevation of serum uric acid. If you examine this patient's urine, you see a sediment of uric acid crystals. This patient has a disease called Lesch-Nyhan syndrome. Lesch-Nyhan syndrome is an X-linked disorder that's caused by a defect in that hypoxanthine guanine phosphoribosal transferase, the HGPRT gene. Remember, this is the key enzyme in the salvage pathway for purines. This is the enzyme which takes these nitrogenous bases and adds it back to PRPP to recycle these things as nucleotides. Without the salvage pathway, all of the purine bases are degraded, and this causes an increase in the production of uric acid. So presumably most of the signs and symptoms of this disease are caused by accumulation of uric acid, which include delayed motor development and this really characteristic compulsive self-mutilation, which is very unique to this disease. A megaloblastic anemia is seen as well. They get gouty arthritis as well, caused by deposition of uric acid crystals in the joints, and they get progressive kidney failure from uric acid deposition in the kidneys. Patients are treated with allopurinol, which is a hypoxanthine analog. It's an inhibitor of xanthine oxidase. When the xanthine oxidase is blocked, this reduces the uric acid levels to normal, and the more soluble hypoxanthine and xanthine are able to be excreted in the urine. This prevents the development of gouty arthritis and the kidney damage, but for some reason that's not really well understood, it doesn't seem to do anything for the neurologic symptoms. Here's a picture that shows this. Allopurinol blocks xanthine oxidase, and so rather than having everything converted to uric acid, most of it's converted to hypoxanthine or xanthine, which are easily excreted by the urine and are non-toxic. Now, there are other biochemical causes of excess uric acids leading to gouty arthritis. You can have a partial deficiency of HGPRT such that you don't get the signs and symptoms of Lesch-Nyhan syndrome, but rather just the accumulation of uric acid. You can have a resistance of the purine synthesis pathway to negative feedback inhibition. In this case, you get oversynthesis of the purines, which leads to increased degradation and overproduction of uric acid. You see hyperuricemia also in a disease called tumor lysis syndrome. This is a disease in which you have a large tumor mass which is treated with chemotherapy. As those cells die, it produces a large load of purines, which results in an overproduction of uric acid. You can also see this in other diseases in which there's increased cell turnover. For example, you can see it in some hemolytic anemias. The other place where you can see hyperuricemia is in renal disease, in which there's a defect in uric acid excretion. So this ends the lecture on nucleotide